Dr. Ho, the stage is yours.
Thank you, Chairperson. I think I have 20 minutes to talk about immunotherapy for colorectal cancers. Let's move. Okay. So immunotherapy for colorectal cancers. So when we talk about immunotherapy, we talk about the antibodies because otherwise we talk about the vaccine and the cells. There will be a little bit of a much longer talk. So the checkpoint inhibitors that we talk about are the CTLA-4 inhibitor and the PD-1 inhibitor. So this slide show the T cell engaging the tumor cells. So you need the T cell receptor engaging the MHC class 1 and a co-stimulator, which is not shown here. So that activates the T cell receptor and the interferon activation afterward. But this activation pathway can be inhibited by CTLA-4 engaging B7 or PD-1 engaging PD-L1. So that switch off the activation of the T cells. So what people do is they use an antibody to block the CTLA-4 or the PD-1, and so that the T cell activation happens. So that's basically what checkpoint inhibitor means. So colon cancer actually has, you can divide into the deficient in mismatch repair protein or microsatellite instability high. So that one is a rare type of colon cancer in advanced setting, about 3 to 5%. In the earlier setting, about 15%, versus the proficient in mismatch repair protein, which is pMMR, or microsatellite stable, which is the majority, about 95% of colon cancer is the pMMR or MSS colon cancer. So the deficient in mismatch repair protein, MSI high colon cancer, actually is a very hot tumor, i.e. it activates the immune response, and it is infiltrated by CD8 T cells and CD4 TILs as well. So it is a tumor that elicits immune response. So we talk about advanced colorectal cancer first, and the rarer subtype, which is a dMMR, because that one is a bit more responsive to immunotherapy. So the landmark study by Dr. Thierry Andre from 5 years ago now, which is pembrolizumab in MSI high advanced colon cancer, this Keynote 177 study. So they randomized the patients to 2 arms. One is chemotherapy, standard chemotherapy plus targeted therapy like bevacizumab or cetuximab, versus single agent pembrolizumab, 200 milligram every 3 weeks. So what we see is that except for 40% of patients who do not seem to respond to immunotherapy, the curve would cross over at about 4 months, and then immunotherapy patients will do better. That means some are non-responders. So not everybody responded. For those who responded, they survived long-term with no relapse of disease, compared to chemo, which performed better at the beginning, and then basically patients develop resistance and then they progress. So the hazard ratio is 0.6. Therefore, overall, it reduced the risk of disease progression or death by 40% versus standard chemotherapy and targeted therapy. This one doesn't work anymore. I think it's about 3 issues. Oh, okay. So looking at the subtypes, most of the subtypes responded. This one is the KRAS NRAS mutant is on the other end of the unity. So, but it is a small cohort. So we don't know whether KRAS NRAS mutant patients are less responsive. After 5 years, which is this year, they published another paper using a doublet, which is nivolumab and ipilimumab. This is a CheckMate 8HW for metastatic MSI high colon cancer. And this study has 3 arms, which is nivo alone, 2 weekly, nivo plus ipilimumab, which is a CTLA-4 inhibitor, 4 doses followed by nivo on its own, and then investigator choice, which is chemotherapy plus targeted therapy. They reported these 2 arms, which is the doublet immunotherapy versus the standard of care. So you can see the curve separated widely. Hazard ratio was 0.21. So this risk reduction of the disease progression and death is significant So this curve is actually very flat, actually better than the single agent pembrolizumab study. So Keynote 8HW actually is kind of practice changing, and using in real life, I also find it is actually more effective than single agent pembrolizumab, which is response rate about 43%. So this is our own humble contribution to the literature, because when you use the pembrolizumab, is for 35 doses. That costs about 600,000 ringgit, so it's a lot of money. So we published our own experience with one DMMR metastatic rectal cancer patients who had limited funding. So we gave him 2 doses of standard pembrolizumab, 200 milligram, 3 weekly, and then good response, back pain disappeared. So, and we gave 100 milligram for 2 doses, that's 3 monthly apart, and then 100 milligram 6 monthly apart. So that was in 2022. So that was the disease back in 2022, para-aortic node, that's paraspinal disease, after 6 doses, which is actually only 4 full doses, because 4 of them are half doses. So tumor disappeared. So I saw him this week, actually. He's still totally fine. Marker is still down. So this is our contribution to the literature, saying that you probably don't need to give it like targeted therapy or chemotherapy religiously every 3 weeks for it to work. Because once you have activated the immune system, the immune cells may do the rest of the work, and patient remains well with the immune surveillance. Much more difficult is the pMMR colorectal cancer, because they tend to be cold tumor. Although having said that, not all the pMMR proficient in mismatch repair protein colon cancer do not respond. Some do respond. This is a tisotype study using FOLFOXIRI plus bevacizumab, which is a triplet chemo plus bevacizumab. So it's a very powerful regime, plus minus atezolizumab, which is a PD-L1 inhibitor. So for FOLFOXIRI, bevacizumab plus minus atezolizumab in a first-line setting. So overall, they noticed a modest improvement in the progression-free survival. 11 months, 11.5 went up to 13.1 months, hazard ratio 0.69. For pMMR group, it was 12.9 months versus 11.4 months. So it means it did benefit some patients, but not as dramatic as the DMMR patients. But if you look at the Kaplan-Meier curves, it is convincing that you do see effect of the immunotherapy even for this many pMMR patients group. So that's just a breakdown to show that all the numbers are more favorable with the arm B, which is the group with the atezolizumab. So they try to find out why patients responded better. So it is to do with, in that cohort, to do with the immunoscore, immune cell score high tumor, i.e. if they have lots of infiltration of the effective T cells and less regulatory T cells, and also TMB high. So tumor mutational burden. So if there's high TMB and high immunoscore, which means there's lots of infiltration of the immune cells, then even for pMMR tumor, they respond to immunotherapy. But actually, the most promising checkpoint inhibitors for MSS colon cancer is these 2 agents, which is botensilimab, which is a more potent type of anti-CTLA-4 inhibitor, and balstilimab, which is just a PD-1 inhibitor. Because the potency, so this enhanced Fc portion of the antibody, it activates the immune cells more, T cells more, and it dumps down the regulatory T cells. For those of us who don't understand what regulatory cells are, they are the ones that dump down the immune response. Our immune response has the effector T cells, and which make the immune system more active, and the regulatory T cells that suppress the immune system. So it is a balance between the 2. So this botensilimab actually can dumb down the immune suppression. So even for this is for pMMR subtype. You can see this waterfall plot. If tumor, one line means 1 patient, 1 bar means 1 patient. So if the tumors shrink to very small, it drops to here. So you can see at least half the patients have some kind of stable disease or responded. This is called spider plot, which is the tumor size versus time. So if a tumor gets smaller, you get smaller. If a tumor gets bigger, then it goes that way. So these are many patients with uncontrolled, untreated liver metastasis. They don't tend to respond very well to checkpoint inhibitors. But for a lot of patients, actually, they get stable disease. So I think for checkpoint inhibitors to work for pMMR or MSS colon cancer, then these two agents are the most promising ones so far. So now people want to bring it to the neoadjuvant setting, i.e. for local colon cancer. So use it as upfront for localized colon cancer. So this is a Keynote 177 in advanced setting and CheckMate 8HW in the advanced setting, which established the role of this in the dMMR colon cancer. But people feel that to give it before surgery is more effective because the neoantigens are out there and the lymphatic drainage is intact. So, and it's also proven in melanoma. If you give it before you do surgery, your immunotherapy works better. So now a lot of effort is in neoadjuvant. Neoadjuvant means give it before definitive treatment, like surgery. So, so this is neoadjuvant pembrolizumab for these localized tumors, not just colon cancer, but also rectal cancer and other gastric cancer. So, so there are some duodenal cancer and some pancreatic cancer. So this is the waterfall plot. So for those who had colorectal cancer, very good response. Overall PCR rate, PCR means the cancer disappears after they give a few doses, 8 doses of the pembrolizumab, is 65%. So for colorectal cancer, 79% of PCR rate after giving the neoadjuvant pembrolizumab. This is the overall cohort. So some patients actually went on to not to have the surgery. They just had the immunotherapy and just watch. So because the tumor kind of shrink and then just stay shrunken. So they just watch it without taking out the tumor. So which is remarkable, only 4 or 5 years ago, that you keep the localized rectal cancer there without taking it out. But they responded so well that people just choose to watch for the time being. So this is a NeoPrism that is announced last year in ASCO. So they actually, for the same group of patients, stage 2 or 3, they select those with a high tumor mutational burden. Tumor, if it has a lot of mutational burden, they respond better to immunotherapy. So, so very similar to the design just now. This is defined as more than 6 mutations per megabase pair, and then they give 3 cycles of pembrolizumab. So rather than 8 cycles, and then resect it afterward. So they also found very high rate of pathological complete response, 59% after 3 doses of pembrolizumab. So very similar to our case report in the advanced setting. So in the neoadjuvant setting, they are seeing this quite regularly, that tumor basically just disappears. Many of us heard this story from dostarlimab from 3 years ago, that they planned for immunotherapy, then chemoradiation, then surgery. So they give immunotherapy, 6 months of dostarlimab. Everybody's tumor disappeared. So nobody went on to have the radiotherapy and surgery. So that's the dostarlimab story. Now they have 48 patients included already, and half of them had the genetic inherited colon cancer, rectal cancer called Lynch syndrome, and the tumor mutation burden is very high, 53.6 mutation per megabase pair. So 42 had completed the treatment, and so far none of them required the definitive chemoradiation and surgery. So the median follow-up now is 17.9 months. So there are the camp that says that if it is not, if the tumor disappears, why you take out the tumor? So that is now kind of the view is a bit divided. Do you take out the tumor now? The tumor has disappeared or not? Actually, Prof. April and I had this discussion last week. So if you have very good response, do you take it out or not? So I think that one is still open question. So the tumor, so you can see that in the study, the PD-L1 score goes down, the CD8 score goes up, CD8 T cell score goes up, and then the CD20 immune cells score goes up. So you can see the immune response if you take out the tumor. So this is another neoadjuvant study. This one is a very famous niche 2 study by Calabi et al. Published last year. So this one they give, again, ipilimumab and nivolumab. So they give 1 dose of ipi-nivo and 1 dose of nivo, and then take it out. So 2 doses. 2 doses as doublet, but doublet and then nivo. And then this also for localized rectal cancer. And then this is a waterfall plot. So each bar represents 1 patient. So you can see everybody, until here, tumor disappeared. And all this, although did not disappear completely, also major response. I almost disappeared. So the complete response is 67%, but a lot of these are actually almost complete response. So with 2 doses of immunotherapy, they get major pathological response. So now we have 3 studies that shows neoadjuvant immunotherapy, the ipi-nivo, the Calabi study, NICHE-2, and the CHECHEK study, which is dostarlimab, and the Ludford study, which is pembrolizumab, using different doses, different duration of neoadjuvant immunotherapy, and reported very dramatic outcome. The Chinese now, they have lots of immunotherapy and lots of new drugs. So they also have their own one called IBI310, reported in ASCO last year with sintilimab and anti-PD-1 antibody, also in DMMR colon cancer, and then report this versus sintilimab alone with single agent. And they reported if they give a doublet, 80% achieve PCR rate. They give a single agent, 47%. So I mean, a lot of the Chinese IO drugs now, some of them, one is coming, tislelizumab is coming to Malaysia, but we hope to get more Chinese IO drugs because they tend to be slightly cheaper and result also very convincing. There's a NICHE-3 study, which is announced just now, this with LAG-3 inhibitor, which is a new target. We have the CTLA-4 and PD-1. Now we have the LAG-3, which has been approved in lung cancer, in melanoma. So LAG-3 inhibitor, relatlimab, so they give the nivo plus relatlimab, and then give 2 doses, 3 doses, and then do the surgery. Also very impressive result. That means either PD-1 inhibitor partner with CTLA-4 inhibitor or partner with relatlimab, which is not approved in colon cancer, you get very good, a doublet seems to have very good response. So actually in ESMO guidelines, still in print, they say that if you have a locally advanced DMMR rectal cancer, you give dostarlimab, you get complete response, you can watch it. Only do salvage resection if the tumor is not, has not disappeared. So that means it's gone to the mainstream. But I don't know whether we all do that or not, because to me it's still very early result. 17 months is not like 5 years. Are we really certain that it won't recur in 3rd year or 4th year or 5th year? So it is, I think, still open question. So that one is for DMMR, which is only about 5%. In early stage, about 15% of colon cancer. So for PMMR, what about the majority? In the original NICHE study, where they first tried the EP and NIVO, they actually had some patients with PMMR, the not so immune responsive colon cancer, and they get a response rate of 27%. So the red ones are the DMMR, but you see a couple of 3 green ones. So these are PMMR. That means some PMMR rectal cancer, also colorectal cancer, also respond to EP-nivo. It's just very hard to pick them out. Previously, we say maybe those with a high immunoscore and with high TMB, but still not certain who to select for the immunotherapy. Next one is using the one we talked about, botensilimab and the balstilimab. So the enhanced CTLA-4 inhibitor, which is more can make the cold tumor more responsive. They also did that in the neoadjuvant setting, and then the test of the efficacy, and they reported quite convincing. So because these are not responsive tumor, so you still 1, 2, 3, 4, 5, 6 patients responded, 50% means responded, 2 did not respond, MSI high, everybody responded. So 6 out of 9 patients responded, very, very convincing. Although it's still a small number, but I think this combination is probably the best checkpoint inhibitor we have for PMMR colorectal cancer. There's the Tarzan study, which is a bit thought-provoking. So if for those of us who do the Rapido regime for rectal cancer, you give radiotherapy 5 fractions and give 4 months of oxaliplatin 5-FU chemo before surgery. This one, they give the radiotherapy, but they skip the chemo. They give bevacizumab, and this is target therapy, and atezolizumab. 1, 2, 3, 4 cycles. 2 of them is doublet, and then they did the surgery at the end. So they found that with no chemo at all, 18% of patients get pathological complete response. Clinical complete response. That means, and for those who get clinical complete response, half of them did not have the surgery. They just watch it. So okay, so the world of colorectal oncology is like if you get clinical CR, you watch it. So I don't know whether this is right or wrong, but that's what people are doing nowadays. Lastly, I want to bring a bit talk about microbiome. So many studies confirm that probiotic, actually gut microbiome, affect the development of colon cancer, and there's dysbiosis when you get colon cancer. And the products are bifidobacteria and lactobacillus, which I think are good probiotic. It can and administration of lactobacillus acidophilus and bifidobacterium lactis can change the microbiome profile, and they produce butyrate. So, for example, like Faecalibacterium, these are good bacteria to have inside the colon. It has a lot of effect on the immune cells, on the CXCR, which is attracting for the cancer cells to proliferate and to go somewhere else. So it has a lot of effect on your immune system for this gut bacteria. So there's now convincing evidence that gut microbiota modulate cancer immunotherapy, and bacteria that are beneficial like bifidobacteria, Faecalibacteria, and Akkermansia. So I think we should make more effort. The Chinese did one study called Renmin 215. So what they did is they give fruquintinib, which is a targeted therapy for like third, fourth line colon cancer, with the immunotherapy drug, tislelizumab, and then fecal microbiota. So from a donor, the good bacteria. So what they need to do is to give antibiotic, vancomycin, neomycin, clear the native bacteria for 3 days, and then purge the patient, cleanse the gut, and then give the other people's bacteria in capsule form. So the stool made as capsule, and then take 30 capsules a day for a few days, for 3 consecutive days. So to transplant the bacteria from another person to the patient. And notice quite reasonable waterfall plot and quite reasonable swimmer's plot. Means there is 20% response in these heavily treated patients, and they check the gut microbiota, also change the more favorable microbiome. So I think this area is remain unexplored, and actually we should have more on it. So that's a summary already. We still have 5 minutes, that's okay. Immunotherapy is effective for advanced dMMR colorectal cancer. It's essential to test the MMR status before determining the treatment. And can we de-escalate the treatment with the dMMR rectal cancer? My own feeling is probably, it looks very promising. And patients certainly want it, because patients don't want to have surgery if they can have no radiotherapy. Longer follow-up needed. For pMMR colorectal cancer, it is a heterogeneous tumor group, and results is inconsistent. So I think more research is needed, and the role of microbiota is a bit underexplored. Thank you.